Management of heart failure can be subcategorized into two subgroups: management of acute heart failure or acute decompensated heart failure, and secondly, management of chronic heart failure. The domains of acute heart failure that include substrate, acuity, severity, triggers, and the presence or absence of life-threatening conditions that warrants immediate and urgent therapy. As for example, presence of cardiog- presence of cardiogenic shock or respiratory failure that has been discussed in elaboration in the previous class. The domains of acute heart failure that include substrate, acuity, severity, triggers, and the presence or absence of life-threatening conditions like cardiogenic shock or respiratory failure has been discussed in elaboration in the previous class. Today's topic is management of heart failure, targeting the common set of symptoms and signs resulting from the chronic congestion and hypoperfusion, as well as the corresponding hemodynamic profiles. Now, coming to the algorithm of acute heart failure management. First of all, confirmation of a diagnosis of acute heart failure. Then go for assessment of clinical status and the hemodynamic profile. Then search for presence of congestion. Presence of congestion means the weight subject, that is the weight subset of acute heart failure that constitutes about 95% of all cases of acute heart failure. On the other hand, absence of congestion means the dry subset that constitute about 5% of all acute heart failure patients. Now search for the presence or absence of the adequate peripheral perfusion. In the presence of adequate peripheral perfusion, the presence of congestion constitute the subset of weight and warmth. Weight and warmth means the presence of congestion with hemodynamic parameters of PCWP exceeding 18 mm of mercury and cardiac index more than 2.2 liter per square meter of body surface area. Then go for assessment of the pattern of fluid redistribution or accumulation. The pattern of fluid retention or redistribution or accumulation can be again subcategorized into two. One, vascular type of fluid redistribution with normotension or hypertension. Vascular type of fluid redistribution means arteriolar stiffness and constriction as well as increased arterial resistance coupled with a reduction in the venous capacitance. And cardiac type of fluid accumulation means presence of peripheral edema, presence of ascites, as well as congestion elsewhere. Now go for the management of vascular type of fluid redistribution. The first option is vasodilators. Second option is diuretic therapy. And for the cardiac type of fluid retention or accumulation, the initial therapy is diuretic therapy, then vasodilator therapy. And in case of refractory situation, go for alpha filtration. That means a form of more or less similar to a dialysis with a targeted, controlled, and rapid removal of the plasma water and sodium without producing dyselectrolytemia. So the management protocol in the vascular type, vasodilator, diuretic. In the cardiac type, the diuretic therapy, vasodilator, and alpha filtration. Now, absence of adequate peripheral perfusion constitute the subset of wet and cold. That means both the presence of congestion and hypoperfusion. That is equivalent to the hemodynamic profile of PCWP more than 18 millimeter of mercury and cardiac index more than 2.2 liter per square meter of the body's surface area. Then check for systolic BP. If less than 90 millimeter of mercury, go for inotropic support, consider pressure therapy and diuretic therapy after correction of the hypoperfusion, and ultimately the mechanical circulatory support in the case of refractory cases. In the case of a BP exceeding 90 millimeter of mercury, go for vasopressor first, then diuretic therapy, then consider other forms of therapy in the form of inotropic support. BP more than 90 millimeter of mercury, go for first vasopressor, then diuretic and inotropic support in the refractory cases. Now the dry subject or dry subset. Dry subset, that means adequate peripheral perfusion. Yes, সেক্ষেত্রে dry and cold. Dry and cold means the perfusion is adequate and failure is well compensated. The option is titration of therapy and optimization of the doses of the drugs already used. And if adequate peripheral perfusion is absent, that constitute a subset of dry and cold. That means no congestion, but there is peripheral hypoperfusion. Then go for a fluid challenge test. If no response, then go for inotropic support. That's all related to the management of acute heart failure. Now, management of chronic heart failure. Chronic heart failure means a long-standing, that is in terms of months to years, heart failure with symptoms and signs of heart failure classically managed by a GDMT, that means guideline directed medical therapy or device therapy in the form of ICD or RCT, that is the desynchronization therapy. ক্রনিক হার্ট ফেলিওর ম্যানেজমেন্টের ক্ষেত্রে কয়েকটি প্যারামিটারের কথা অবশ্যই আমাদের মাথায় রাখা উচিত। নাম্বার 1, NYHA class. Number 2, stage of the heart failure. Number 3, status of the LV ejection fraction. So combining these three, NYHA classification, stage of heart failure, and LV ejection fraction, we should go for the management of chronic heart failure. Now, there are 4 main pillars or therapeutic strategy for the management of chronic heart failure. Number 1, ARNI or ACEI or ARB. Number 2, evidence-based beta blocker. Number 3, mineralocorticoid antagonist. And number 4, SGLT2 inhibitors. This is the fantastic 4 for management of the heart failure. Indications for ARNI. NYHA functional class 2 to 3. Heart failure stage C. And it also be administered in conjunction with a background of GDMT for heart failure in place of ACEI or ARB. Indications for ivabradine, LVEF less than or equal to 35% on maximum, and heart rate maximal tolerated dosage of beta blocker is more than 70 beats per minute, and NYHA class 2 or 3. So indications of ivabradine. Number 1, stage C heart failure, that means heart failure with symptoms and signs. NYHA functional class less than equal to 35%. Then the LVEF less than equal to 35%, and sinus rhythm with a resting heart rate more than 70 on maximally tolerated doses of beta blocker. Indications of SGLT2 inhibitor. HF with reduced ejection fraction, that means ejection fraction less than or equal to 40%. Second, NYHA classification, 2nd to 4 or 2 to 4, and it may be administered in conjunction with a background for heart failure in addition to other drugs. Or indications for use of very C-cart or novel approach, but even in the group of 2A evidence. This is the heart failure with reduced ejection fraction with LVEF less than equal to 45% on maximum tolerated doses of GDMT, but worsening symptoms of heart failure. Now at stages for heart failure, stage A, that means at risk for heart failure, the presence of hypertension, go for optimal therapy of hypertension and control of hypertension. Presence with type 2 diabetes mellitus and CVD or high risk for CVD, control of the risk factor and control of the metabolic status. The drug of choice is SGLT2 inhibitors or on occasion ECEI or ARB. Go for CVD, optimum management of the CVD, that means management of the peripheral arterial disease, etc. etc. Patients with exposure to cardiotoxins, management regarding to the treatment of the toxic agents applied or toxic agent that is responsible. Then first degree relatives of patients with genetic or inherited cardiomyopathy, genetic screening and counseling. Lastly, patient at risk for heart failure, natriuretic peptide estimation and manage accordingly, or patient for at risk for heart failure, validated protocol for confirmation or exclusion of heart failure with preserved ejection fraction, that means HFpEF. Now, pre-stage heart failure, that is heart failure stage B, patients with LVEF less than 40% ACEI, এক্ষেত্রে একটা প্রশ্ন উঠতে পারে যে এখানে তো ইজেকশন ফ্র্যাকশনের প্রশ্ন আসছে কেন। স্টেজ বি বা প্রি হার্ট ফেলিওর স্টেজ মিনস অ্যাবসেন্স অফ কারেন্ট সিমটমস আর সাইন্স, সেক্ষেত্রে কিন্তু ইজেকশন ফ্র্যাকশনের কথা মেনশন করা হয়নি। দ্যাট মে বি নর্মাল or that may be abnormal. So, pre-heart failure, LVF less than equal to 40% ACEI, or pre-heart failure with recent myocardial infarction with LV ejection fraction less than equal to 40%, then ACEI or ARB plus minus beta blocker, that is evidence based beta blocker. সেগুলো কি কি? নাম্বার 1 Carvedilol, নাম্বার 2 Bisoprolol, নাম্বার 3 Metoprolol, Succinate. Evidence based beta blocker are 3: Bisoprolol, Carvedilol and Metoprolol, Succinate. Not tartarate. Succinate বৈশিষ্ট্য হচ্ছে once a day dosing schedule or protocol. The patients with LVF less than equal to 35% or 30% expected survival more than 1 year, 40 days post MI, then go for ICD, implantable cardioverter defibrillator, and the patients with non-ischemic cardiomyopathy or inherited cardiomyopathy, genetic screening and genetic counseling. Now, the classical management of chronic heart failure stage C, NYHA class 1 to 4. Now, it includes a stepwise fashion. Step 1, confirmation of a diagnosis of heart failure with reduced ejection fraction. Then address congestion. Then initiate GDMT. All these three should be based or should constitute a specific clinical scenario. Then go for titration of drugs or GDMT to the optimum or target dosing, and evaluation on the basis of symptoms and signs, that is the clinics, labs, health status and LV ejection fraction. Then go for the consideration of the specific clinical situations. Then go for the implementation of additional GDMT or device-directed therapy. Then go for reassessment of again symptoms and signs, lab test, health status, LV ejection fraction, and the last stage, that is stage 6, that is referral for heart failure center for specialized intervention. Now step 1, that is the scenario of heart failure with reduced ejection fraction, LV ejection fraction less than or equal to 40%, and heart failure stage C. Institution of GDMT that include ARNI, functional class 2 or 3, ACEI or ARB, functional class 2 to 4, and then you may add beta blocker, then MRA, then SGLT2, and lastly diuretic therapy. So initiation of GDMT include ARNI or ACEI or ARB plus beta blocker plus MRA plus SGLT2 inhibitors, and lastly diuretics if needed. Now the step 2, that means titration of doses to the optimum dosing or maximum tolerated dose and re-evaluation that may result in two subsets. The subset 1, heart failure with ejection fraction less than or equal to 40%, অর্থাৎ একই রকম অবস্থায় থেকে গেছে, যেটাকে বলা হচ্ছে persistent heart failure stage C. Second subset is heart failure with ejection fraction more than 40%. That means heart failure conversion হচ্ছে HFimpEF, heart failure with improved ejection fraction. In the second case, go for continuation of the GDMT with serial reassessment and optimization of the dosing, adherence, patient education, and address the goals of therapeutic target. Now the first subset LVF less than or equal to 40%, we should consider the specific clinical scenario. As for example, NYHA class 2 or 3, especially in Afro-American ethnicity, we should go for hydral nitrate. That means hydralazine plus isosorbide dinitrate. The scenario of NYHA functional class 1 to 3 LVEF less than or equal to 35%, expected survival more than 1 year, we should go for ICD. And the third clinical scenario, NYHA functional class 2 to 3 or ambulatory cases 4. The LVEF less than or equal to 35%, normal sinus rhythm, and LBB or wide QRS complex with QRS duration exceeding or equal to 150 milliseconds, we should go for cardiac resynchronization therapy cases, or refractory cases consider additional therapies. Then the step 5, refractory heart failure, that means translation into the stage D, or there may be improvement, that means the improvement in the ejection fraction. In the second case, again, continuation of the GDMT, optimization and titration of the dosing, patient education, and the address goals of medical care. In the first case, we should go for mechanical circulatory support, cardiac transplantation, or palliation, or newer investigational studies, if any. So, this is the classical step-wise management strategy in a case of chronic heart failure, stage C, with reduced LV ejection fraction. Now, ARNI, Plan A. Institution of ARNI, initial institution হতে পারে NYHA ক্লাস 1 to 3। তাছাড়া যদি কোনো পেশেন্ট থাকে ACEI অথবা ARBতে, তখন 36 আওয়ার্সের একটি ওয়াশ আউট পিরিয়ডকে রাখতে হবে in order to avoid the complications of angioedema and others. So 36 hours washout period, that means keep off ACEI or ARB for 36 hours, then initiate ARNI. Monitoring at an interval of 1 to 2 weeks and following initiation as well as during titration as well as continuation. এক্ষেত্রে আমাদের মনিটরিং করতে হবে কিসের উপর বেশ করে। নাম্বার 1, renal functional status. Number 2, blood pressure. Number 3, blood electrolytes. So, monitoring should be done by means of BP, electrolytes, and renal function. Initially at 1 to 2 weeks following institution, then on a regular basis at an interval of 14 days during continuation as well as titration of dosing. Second is ACEI or ARB. যে ক্ষেত্রে ARNI is not feasible, সেক্ষেত্রে আমরা ACEI অথবা ARB ইউজ করতে পারি। এক্ষেত্রে মনিটরিং প্যাটার্নটা মোর অর লেস সেম, দ্যাট মিনস blood pressure, renal function, and serum potassium or other electrolytes. The sequence is same at 1 to 2 weeks initially, then at an interval of 2 weeks during continuation as well as titration of therapy. Then go for the mineralocorticoid antagonist. Caveat: the renal functional status should be adequate and the serum potassium level should be less than 5 millimole per liter. We can add mineralocorticoid antagonist therapy. Monitoring is mainly for the serum potassium concentration and renal functional status. Then go for SGLT2 inhibitors. এক্ষেত্রে renal functional status with GFR more than or equal to 25 ml per kg per square meter of body surface area is a must. Now, Plan E, evidence-based beta blocker, again repeating the 3 drugs: Carvedilol, Bisoprolol, and Metoprolol. Succinate, not tartarate. Then diuretic agents. In selected cases with excessive volume overload, we should add diuretic in the form of loop diuretics like furosemide. And in a setting of diuretics, monitoring should be done by means of serum electrolytes. Now, Plan G, that is the hydral nitrate. In cases of refractory heart failure, especially in the Afro-American individuals or populations with poor socioeconomic status, we should go for addition of hydral nitrates. That means a combination of isosorbate dinitrate and hydralazine. Plan H, that is Ivabradine, NYHA functional class 2 to 3, heart rate at more than 70 on maximal tolerated doses of beta blocker, we should add Ivabradine. Initiation of therapy should be dependent on age of the patient. If age less than equal to 75 years, begin with a dose of 5 mg twice a day. Age more than or equal to 75 years, we should start with a dose of 2.5 mg twice a day. Then, according to the situation, that means on the basis of the heart rate, we should titrate in the downgrade fashion or we should titrate in the upgrade fashion. In the heart rate below 50, then we go for reduction of doses. On the other hand, if the heart rate is in the range of 50 to 60, be static in your decision. And if the heart rate exceeds 60, we should increase the dose of ivabradine. Now the plan is Verisugot. Verisugot সাধারণত আমরা খুব একটা ইউজ করা হয় না। Indication is 2A, that means beneficial effect is marginally better than detrimental effect. এক্ষেত্রে বলে রাখা ভালো, আমাদের যে লেভেল অফ এভিডেন্সগুলো থাকে তার মধ্যে বা ইন্ডিকেশনস থাকে 1, 2A, 2B and C. 1 means definitely beneficial, 2A marginally beneficial, 2B may be beneficial, 3 that is the detrimental. So indications are very got is 2A, that means NYHA functional class 2 to 4, LVEF less than equal to 45% and worsening of symptoms despite optimum GDMT. That's all regarding the heart failure strategy. এক্ষেত্রে দুটো জিনিসের কথা আগে বলা হয়েছিল, একটা হচ্ছে আইসিডি আর একটা হচ্ছে কার্ডিয়াক রিসিনক্রোনাইজেশন থেরাপি অর্থাৎ সিআরটি। হোয়াট ইজ আইসিডি? ইমপ্লান্টেবল কার্ডিওভার্টার ডিফিব্রিলেটর। দ্যাট মিনস যখন কোনো হার্ট ফেলিওরে এরিথমোজেনিক ফোকাস থাকে, সাসপেক্টেড এরিথমিয়া or presence of arrhythmia, placement of a device similar to that of a pacemaker beneath the clavicle or collarbone. That may be subcutaneous, that may be chamber dependent, the অর্থাৎ right ventricle or right atrium. The main purpose হচ্ছে to sense the electrical aberration in the heart and correct it accordingly. This is the implantable cardioverter defibrillator. Subcutaneous, atrial or ventricular placement of the leads and the device or generating machinery, that means machinery with the purpose of generating electrical impulses according to the situation of the cardiac electrical activity. The machine is placed in the infraclavicular region and lead are placed through the transvenous approach, that means transsubclavian approach. This is the implantable cardioverter defibrillator. ICD, this is the pulse generating machinery, and this is the transverse placement of the catheter in the right atrium, in the right ventricle, or it may be in the subcutaneous tissue. This is the conduction system of the heart. So, implantable cardioverter defibrillator is a management tool, especially heart failure with class 1 to 3 L ejection fraction less than equal to 35%, and stage C. This is also an example of the ICD. This is the cardiac dysrhythmia that is automatically detected by the ICD, and ICD generate impulses to counteract the cardiac dysrhythmia. Now the resynchronization therapy. রিসিনক্রোনাইজেশন থেরাপিকে সহজ পরিভাষায় বলা হয় ফিজিওলজিক্যাল পেশিং। অর্থাৎ আমাদের যে কার্ডিয়াক পেশিং করা হয়, দ্যাট মে বি সিঙ্গেল চেম্বার, দ্যাট মে বি ডুয়াল চেম্বার, দ্যাট মে বি বাইভেন্ট্রিকুলার। আর রিসিনক্রোনাইজেশন থেরাপি মানে হচ্ছে যে অ্যাট্রিয়াল কন্ট্রাকশন, রাইট ভেন্ট্রিকুলার কন্ট্রাকশন, লেফট ভেন্ট্রিকুলার কন্ট্রাকশন, অর্থাৎ সমস্ত কন্ট্রাক্টিলিটিকে সিঙ্ক্রোনাইজ করা। এক্ষেত্রে বেসিক তফাৎটা হচ্ছে পেসমেকারের থেকে, যে এখানে 2 বা 3-এর বেশি লিড প্লেসমেন্ট হয়। ফার্স্ট লিড রাইট অ্যাট্রিয়াম, দেন রাইট ভেন্ট্রিকল, and the third lead in the left ventricle through the coronary sinus. Right atrium, right ventricle, left ventricle, 3টে লিড প্লেস করা যায় এবং মেশিনটাকে সে একই রকমভাবে দ্য সাবকিউটেনিয়াস পকেট ইন দ্য ইনফ্রাক্লাভিকুলার রিজনে প্লেস করে রাখতে হয়। উদ্দেশ্য হচ্ছে সিঙ্ক্রোনাইজেশন অফ দ্য contractility of the various chambers in an attempt to optimize the ejection fraction or optimization of the ejection of blood in the peripheral circulation. This is the CRT device. Here the subclavian approach, right atrium, right ventricle, and through the coronary sinus in the left ventricle. Right atrial lead, right ventricular lead, and the coronary sinus lead. Virtually this is designed for the left ventricle. So the contraction of the various chambers should be synchronized through the placement of a pacemaker-like instrument known as CRTD. It is CRT devices. Now, management of heart failure with preserved ejection fraction, অর্থাৎ LVPEF. The classical drug is SGLT2 inhibitors. এখন ডায়াগনস্টিক ডিলেমা থাকতে পারে। ডায়াগনস্টিক ডিলেমাকে কাটিয়ে ওঠার জন্য প্রথমে আমাকে যেতে হবে হার্ট ফেলিওরের ইজেকশন ফ্রাকশন LVEF মোর দেন অর ইকুয়াল টু 50%। কয়েকটি বিশেষ জিনিসের কথা মাথায় রাখতে হবে। BNP concentration, that is the natriuretic peptide level, is usually low, contrasted to the level seen in reduced ejection fraction, and the natriuretic peptide is inversely proportional to the degree of obesity. Then the symptoms and signs of heart failure by a structural and or functional abnormality plus corroboration by means of the elevated natriuretic peptide. Ambulatory subjected ক্ষেত্রে BNP less than equal to 35 picogram per ml in hospitalized, in the NT-pro BNP more than or equal to 125 picogram per ml, but in hospitalized subject BNP more than 100 picogram per ml, and NT-pro BNP is more than 300 picogram per ml. পুরোটা মিলিয়ে তৈরি হচ্ছে হার্ট ফেলিওর উইথ হার্ট ফেলিওর। এর পরবর্তী স্টেজে আমরা যেটা যাচ্ছি সেটা হচ্ছে টার্গেট অফ থেরাপি in a setting of heart failure with preserved ejection fraction. First হচ্ছে structural remodeling. Target of therapy ARNI, MRA, SGLT2 inhibitors and GLP-1 agonist. Second হচ্ছে autonomic dysregulation or dysfunction. Stimulation based therapy or nerve ablation. Autonomic dysfunction এগুলোকে কি vagal stimulation, brain stimulation or deep brain stimulation, etc. Then cardioembolic stress and obesity, GLP-1 agonist, SGLT2 inhibitors, ARNI and MRA. Third is hemodynamic alterations. Hemodynamic alterations means ARNI, ACEI or MRA, SGLT2 inhibitors and GLP-1 receptor agonist. Then the microvascular inflammation, that is the meta-inflammation or metabolic inflammation, GLP-1 agonist, SGLT2 inhibitors, ARNI and MRA. So, therapies will be targeted to the structural remodeling, autonomic dysfunction, cardiometabolic stress, obesity, hemodynamic consequences or alteration, and lastly, microvascular inflammation. Considering all these three, the central point is SGLT2 inhibitors. Now, assessment of the heart failure with preserved ejection fraction. First mode of assessment is HFpEF, H2. First stage heavy, that means body mass index exceeding 30. Second H on 2 antihypertensive medication, scoring body mass index more than 30 kg per square meter, 2 on 2 antihypertensive medication, 1. F, fibrillation, that means atrial fibrillation, score 1. Then P, pulmonary arterial hypertension, pulmonary arterial pressure exceeding 35 millimeter of mercury on Doppler echocardiography, score 1. H capital E by small e exceeding 9 on Doppler echocardiography, score 1. H2FpEF score 6 or more is suggestive of heart failure with preserved ejection fraction. Now, assessment of heart failure prior to therapy. HFpEF score, that means assessment of heart failure with preservation of LV ejection fraction should include first P, that means pre-test assessment, symptoms and or signs of heart failure, then comorbidity and risk factor, then standard echocardiography. Now, E for echo and natriuretic peptide. এক্ষেত্রে হচ্ছে comprehensive echocardiography. Echocardiography various subsets আছে, এখানে comprehensive echocardiography and estimation of the natriuretic peptide levels. F1, that means functional testing in case of uncertainty. সেটা ইনক্লুড করছে the diastolic stress test or stress echocardiography. It is the functional test include diastolic stress test or exercise echocardiography, then invasive hemodynamic studies. And the F2 means final etiology, final imaging, that is cardiac MR, CT, or PET. Second, the endomyocardial biopsy. And third, genetic screening and counseling. So, heart failure assessment, that is the PEFF score, P pre-test assessment, E echocardiography and natriuretic peptides, F1 functional testing, and F2 final testing for etiological diagnosis. Initiate with SGLT2 inhibitors, then go for assessment of fluid retention in YHF functional class 2 to 4. Fluid retention, that means titration of doses of SGLT2 and the supplementation with diuretic therapy. So, assessment of fluid retention in YHF functional class 2 to 4, titration plus supplementation, titration of dosing of SGLT2 inhibitors and supplementation with the diuretic therapy. Now, the ejection fraction, irrespective of ejection fraction in case of female and ejection fraction less than 55 to 60% in case of male, with evidence of the fluid retention, addition of the mineralocorticoid antagonist. Then, again, in case of female, irrespective of the ejection fraction, but in male, ejection fraction less than equal to 60%, we can add ARNI. And lastly, for all eligible individuals who cannot take due to intolerance, add ARB. So initiation of SGLT2 inhibitors in case of heart failure with preservation of the valve ejection fraction. Then in case of fluid retention with NYHF functional class 2 to 4, titration and supplementation. Ejection fraction less than 55 to 60, and in female, irrespective of ejection fraction, addition of MRA, or in case of male, again, ejection fraction less than 55 to 60%, and ejection fraction, irrespective of ejection fraction, in case of female, addition of ARNI may be justified. In case of intolerance to ACEI or ARNI, we should go for addition of ARB, because initially I have told therapies should be targeted to structural remodeling, autonomic dysregulation or dysfunction, cardiometabolic stress and obesity, hemodynamic alterations, and the microvascular inflammations previously. In case of heart failure with preserved ejection fraction, the risk stratification and management or control of the comorbidities is a crucial and essential, or even the most important part. These are hypertension, diabetes, obesity, sleep apnea, chronic kidney disease, atrial fibrillation, CAD, coronary arterial disease, and heart failure with preserved ejection fraction. So management should be accordingly. Atrial fibrillation যখন ডিটেলসে পড়ানো হবে তখন বলা যাবে ম্যানেজমেন্ট অফ atrial fibrillation, management of hypertension, coronary artery disease, type 2 diabetes mellitus, and management of the chronic kidney disease, sleep apnea, and obesity. That's all.